Okay, all right, let's go. So, I'm going to talk about feet. It's the other end of your body. You don't see it that often, and you only think about it when it hurts. So, what can I say about feet? Well, it started about just over a year ago. So September 2016 was when we started our guidelines, and our group is a multidisciplinary group. So we've got 7 podiatrists, we've got a pediatric dermatologist, we have a physio, we have a dietitian, a nurse, and patient representatives. And I'm also glad to say it's international. So we have people from here from Australia, we have people from the UK and other parts of the world as well. And we're hoping that this will be completed by September next year. So, feet. Now, for me, I have been involved in EB for 19 years. I guess I was the first EB podiatrist. I was at Great Ormond Street, where I still am today. And when I came along, David Atherton, who was a dermatologist and paediatric dermatologist there, said to me, because I worked next door at the old homeopathic hospital, he said, I work in this condition, do you think you can help? We get lots of foot problems, we get calluses, hyperkeratosis, and blisters. So I sort of walked along, and had a look, and I thought, interesting. So my first area was actually looking at wound management, as opposing to podiatry as such. And I come from a very, as we've talked about today, from a very holistic world and very much to do with natural product world. So I used to have something called marigolds, and I used these different extracts of marigolds for treating different skin, nail and bone conditions. And so that was my introduction. 19 years on, life has greatly changed and podiatry has greatly changed. And over the last few years, what I've really discovered is the lack of podiatry in EB around the world. In fact, as we what this presentation will be talking about today will be the effect of the guidelines that we're doing, but more importantly, what clinical practice is out there. So looking at EB podiatrists, well, in the UK, there are 4 centres, 2 adult, 2 paediatric. I work at Great Ormond Street, and I've been there the longest. We've had Rodney, who's just recently retired at St Thomas's, who deals with the adult service. We have my co-lead to the guidelines, Mark, who unfortunately couldn't be here today, who works at Solihull, which is the adult service, and recently started the Birmingham Children's, and his colleague Lisa. Fortunately for, I guess, this side of the world and for Day, many years ago she invited me here, and I've been part of the EB adult service over at St George. And over the last couple of years, I've also now been helping out with the EB service over in Melbourne, where we have Lewis, who's also a podiatrist, Australian trained, who has basically been the paediatric EB podiatrist. So what I'm going to start off with is assessment and clinical pictures. So for me, it's what are we treating? As a podiatrist, podiatry is different around the world. So in the UK, we're probably very medicine orientated. So we're interested in dermatology, rheumatology, and so on. This side of the hemisphere, it seems to be much more sports related. It's much more about biomechanics. It's about insoles and orthotics. And as most of you may well know, and especially EB patients, that you can't go and get a rigid orthotic and put it in your shoes because it's going to make your blistering worse. It might make you mechanically more stable, but it actually isn't going to help you. So what are the things that we're looking at? So obviously here we have the blistering and the scarring that we can have on the feet. Hold on, I've lost my lost nails. Well, there were some lost nails, and they're really lost now. Don't worry. Dystrophic nails, hyperkeratosis, fibrous neurovascular hyperkeratosis, so nerve endings, which are very sensitive and painful. So then management. So the management I'm going to talk about is my management, what I do, management of what is out there. So foot care advice, this is things that we have put together, and in no ways is comprehensive. Again, I think today the thing that really resonated with me is what Humphrey said this morning, actually, we take our advice from our patients. We sort of listen and see what we can do to sort of interact. And very much what Jane and Caroline said earlier on. We're not experts in anything. We're probably experts in our own field, but actually what we're trying to do is have a partnership to see what works for you and see if we can incorporate that and that can work across the community. So what can I do? So we designed a assessment form, and one of the hopes that we have, which we started to do in the UK, is to actually be able to assess all our patients in the same way when it comes to their feet. So I was fortunate enough, one of the papers I did for ASDR a few years ago here was actually to develop a questionnaire and assessment tool that we would use to take information on. And I hope that we can then use this across all the other centres. So when I'm treating patients, I'll have patients with dystrophic nails, which are very difficult to treat. And of course, the worst part of this is, it's a baby. You're not going to knock out a baby to cut their nails because it's very difficult. But there are techniques that we as podiatrists use, which maybe dermatologists, nurses don't use. And here, I'm able to use tissue nippers. I can reduce the size of the nail. I have black files and separators where I can lift and actually remove tissue. And so we can make the nail better. I'm not going to kill the nail, but I can at least make it comfortable so they're not going to scratch their faces or have open wounds. In the same way, hyperkeratosis. So, this is one of our kids from Great Ormond Street. And this poor girl over here, and I've known her since a baby. She's now about 17 years and transitioned to the adult service. And when she started, her hyperkeratosis was so bad, and she'd been taken down to the surgeon, she'd had these removed, but a few weeks later they're back. You can't keep going through that process. So this was a technique we used, and after a week of treatment we were able to reduce down the hyperkeratosis. Again, this was using an extract from the marigold plant that we use in London. So what advice do we give? Some of it is pretty much sensible and normal advice. Clean your feet, make sure when you've come out of the bath you dry between the toes, wear the right type of socks, things that are basically not going to seem to irritate the skin. We also look at things like trimming our nails, filing our nails, moisturising. So, as we talked about this morning in some of the talks about placebo, actually, well-being is the most important thing because, frankly, most of us do not look at our feet. As I said earlier, unless our feet hurt, we don't see them. They're the other end of the body and they're hidden away from us for 90% of the day. So those are very important. So other areas we looked into were things like socks. And some of you may have already come across the silver-lined socks. There's bamboo socks. There's a few other socks I've been told today about. Insoles and orthotics. I'm going to go into that in a little bit more in a moment. So the prevention of blisters. Blisters on feet are difficult because, yes, we've got dressings, and dressings can help to an extent. There's a lot of people in our London clinics who don't like dressings, won't wear dressings. So we have to think of other things that we can do. So the old 2 pairs of socks actually works really well for some of our patients. So if that works, that's a way to proceed. Insoles and orthotics, let me just move on. That's the silver line. So the idea of the silver technology has really been based on the fact that silver fibre is a good conductor. So if something's hot, it will take away the heat and is able to sort of move it away. So a lot of products, as you know, from different sort of medicinal garments and so on, have got silver fibre in them. So functional orthotics. So as a podiatrist, when I am looking at any patient, I would want to get them balanced. Now, what we often forget is when we're born, we're all flat-footed. So we waddle like ducks to the age of 6. At the age of 6, the valgus rotation of the heel takes place, and this brings up our arch. But 9 out of 10 people in the population, the arch hasn't gone to 0. It's 3 degrees inverted, which means we overpronate. So we have a tendency to flatten our feet. Now, mechanically speaking, if you're walking in a shoe which isn't supported, you're overloading the forefoot during your gait. It means your foot collapses and it splays your bones. So it's like a bag of loose bones going in every direction, rubbing, causing friction on your skin. Now, imagine that in a shoe all day long with heat and friction. So you're having that across the board. So someone with EB, that's 10 times more stresses on their skin. So what we try to do is to make something that will give them support. So in the podiatry world, we will construct a casted orthotic. Now, I'm very anti-casted orthotics, mainly because most of them are rigid and hard. Now, as I said earlier, 90% of the population are flat-footed. So if you've got that with over-the-counter products, so there's plenty of what we call prefabricated insoles and orthotics, they will do the job for you, and often they are softer and semi-rigid. So this is an example of an orthotic, basically. So it's functional, but this is over-the-counter, so you can buy these in athlete's foot and so on. And you would have underneath a stabilizing base, which is normally made of a material of a shell. But then above it, you would have a cradle to hold the foot into place. You would have a material like Poron or EVA. Now, Poron's a good, easy density. It gives you shock absorption, but it will also help to position your foot during the gait cycle. After that, we look at cushioning soles. Now, cushioning soles are things like, as I said, Poron. This is something that we've introduced into the EB community, both in the UK and in Australia. And basically, the same sort of principles as ordinary Poron, but with this layer, this Corzorb layer, which basically has silver. Again, it has a cooling action, an antibacterial action. So if you kind of like, the nearest thing I can, if those of you have got Skechers memory foam walking shoes, having that sort of cushioning underneath your feet. So I thought the best way of actually explaining the benefits are actually showing you a case. So here we have a 46-year-old RDEB patient of ours who came to see us in Sydney. And basically, you can see there's a lot of issues going on with their feet. And this is the sole of their feet. So the left foot looks actually pretty good, well moisturized, no lesions. Whereas the right foot, you can see there's a lot of pressure, hyperkeratosis, and scarring at the ball of the foot. So what we did was what we call a foot scan. So we have a foot plate, which is used in most podiatry practices. In fact, I think if you go into places like Athlete's Foot, they've got these things you can now stand on. If you're buying trainers, it gives you an idea of your gait and the position of your feet. So the left top picture shows barefooted, this patient standing on a plate. The left foot actually doesn't look too bad. So green signifies good, meaning not too much pressure. Red means a lot of pressure. There's a little pressure on the heel. On the right one, you see a lot of pressure on the ball of the foot, but you don't see the heel. And the reason you don't see the heel is because there's contractures of the heel, which means the heel doesn't hit the ground. So what we then did was we then had the patient had orthotics made, and she put them into her shoes, and we got them to stand on the plate again. Wow, her heel's touching the ground. That's fantastic. But look at that red pattern. There's immense pressure on the ball of the foot and the heel area. So we then put a Corzorb insole on top and then got her to stand. Instantly, you can see the pressure is reduced. So just doing a little extra cushioning has made a significant difference to walking and cushioning. So sometimes we have to be a little bit lateral-minded about things and actually take on board other technologies to help. So in an ideal world, that would be the type of shoe we would look at. But I can guarantee you no one in this room would wear that shoe. So that is always the other issue we have. And I know later on we're going to have someone talking about the glove project. I'm now involved in the Reboot project, which is similar to the glove, but to do with the feet. And one of the things we're hoping to develop is a shoe or a sock or some sort of sole that will be able to harness the foot and give it medication and so on. But I'll leave that to later. So back to the guidelines. So to me, what's important to our EB patients? So when we were designing our guidelines, we as a group sat around and thought, well, it doesn't matter what we think, it's what our community thinks and what do they want from us. So one of our members, Beata, she's a nurse at Great Ormond Street, not to do with EB, has an EB child, set up a Facebook survey monkey. And it went out to everyone, and 81 responses came back. But what was really good about it was it gave us some very clear information. So the first question was really, do you need foot care and podiatry care? And you can see, actually, majority of the people that on the survey said yes. The second question was, what were your problem areas? And there's a host of things there. So I'm not sure how good this is, but things from dystrophic nails, blistering and wounds, mobility, shoes, hyperkeratosis, fusion of toes, dry hardened areas. And so that gave us an idea, well, actually there's quite a few issues we need to look at and problems we need to look at. And then how often with your feet would this affect your activity? Because that's often what we forget. It's not just there's a lesion or a problem, it's what you can do. What we want to do is improve quality of life. So if someone is able to walk to the end of the road and back, get a newspaper and come back, that's improving their quality of life. So whatever we can do to aid and help that, that's what we want to do. It doesn't have to be a big thing. It has to be something that's useful. So we looked at the effects on activity, then we looked at the effects on which problem areas they felt that would help in our guidelines. So again, dystrophic nails, blistering, mobility, exploring the most suitable footwear, hyperkeratosis, fusion of toes. So again, across the board, everybody wanted these things to be talked about and hopefully dealt with. Question 5 really was concerning relating foot care to affect the relevant guidelines. And again, for us, it was sort of taking on board points like recommending 100% cotton socks. Could we go and speak to manufacturers and would they be able to do that? Finding the right shoe and sock. For me, the number one seemed to be always footwear. Footwear is a big problem. And addressing footwear for us, again, as Jane and Caroline said earlier, in the UK it's much easier. I have vast number of shoemakers, shoe shops, brands I can recommend. And I know in my practice in Sydney, it's not the case. Just a simple brand like FitFlop, which we do really well with in the UK, there is only a minimal amount of their stock here. So suddenly it's hard to get hold of. Cost is twice as much, if not 3 times as much as the UK. So all these factors do come into it. And then the next question we asked was, what do you do to help prevent your blistering of your feet? And the majority of patients had dressings. Some used Vaseline gauzes, some used seamless socks, others used creams, some had custom-made shoes. Next question was, how do you think EB patients would be supported relating to foot care? Supported in the community, that was important. Supported in hospitals, supported in their own practices and their homes. Because that's sometimes, in a big geographical area like Australasia, it's very difficult. You're not going to have someone down the road, as to us in London, where people can travel maybe a couple of hours and then be with us. Oh, 2 more. All right. Any time now. Want to go the other way? There you go. So the last 3 questions were, what type of EB do you have? And this was important because it was kind of what I expected. The majority were EB simplex patients, then it was the dystrophic patients, and a fewer were junctional patients. And then what age group? What I really liked about this, it was across the entire spectrum. So we didn't just have, very young or very old. We had a good group across. And then the final question, which was probably the most important question, and very relevant to the audience here, was, where do you live? So as you can see, there was lots in Europe who answered, quite a few in North America, a few in South South America, but no one in Asia, no one in Australia, New Zealand had actually answered this link. And here I am standing in front of you. I've started, so I will finish. It would be really important if someone could actually, feedback, and we will make that link available. So, last couple of slides. So, what we have done from our work is basically formulated the clinical questions from what we've had. We're currently appraising the research papers and the current evidence base. We're preparing to write the guidelines, hopefully, as I say, by next year. My acknowledgements here, I would like to thank Deborah International and Deborah UK for helping to fund these guidelines and contributing to our travel to this conference. I'd like to thank the EB Podiatry CPG group, without who I wouldn't be here, and the information and all the work we've done so far wouldn't be there. And especially Katia, because without if you're doing a guideline, having Katia as part of your guideline makes your life easy. And I'm sure the girls will tell you, before Katia arrived and her influence, this was a very difficult thing to achieve. And then I'd like to thank Dede and Adam, who helped with the clinical study. And then I've 3 photographs left. So this is our podiatry conference from last week in England. We had Scotty, who's part of one of our trustees for Deborah UK, and Mark, who's my co-lead for the guidelines, at our podiatry conference. So we have around 1,600 podiatrists that turn up for this conference every year. So we had a stall, and one of my roles, which I guess it's hot off the press, is I've now been appointed by Deborah UK to be Deborah Podiatrist for UK to develop what we want in training and skill and helping our centres with podiatry care. And we hope what we can do is actually deliver that to the vast majority of podiatry so they can see patients locally, not just having to come to centres. And this picture is important because a year ago we had the royal visit, and Camilla is our patron, and she's the patron of the College of Podiatry, and she came to Great Ormond Street because I hosted an event for the college because we wanted to show what work we do. And she was fortunate to meet little Noah, who's one of our Dowling Mirrors, and his family. And with that, we had Jim Malario and Anna there as well. And just to take the plight of where we need to be and getting that message out and having the ability to make sure that the word is out there. Thank you very much.